Okay, well, we're going to go ahead and get started. Welcome. I am Justin Whitt, Program Director of the IU Health Ball Family Medicine Residency Program. All of you today tuned in know me, and we're going to be talking about H. pylori disease. H. pylori disease is very common and affects a good percentage of our population. And this is something that may be a practice gap for many of us that potentially we need to be screening more patients for H. pylori. So as a disclaimer for this presentation, it is intended for general education, is not provided as medical advice or substitute for advice of a personal physician. I have no financial interest, ownership in, or other relevant financial conflicts with this presentation. I've received no goods or services, and it's based on the best available evidence at the time of presentation. So our objectives today are to review common presentations of H. pylori. Those can include dyspepsia, peptic ulcer disease, and gastric cancers, and to review current evidence for H. pylori treatment. So H. pylori is a very common organism. It colonizes about 50% of the world population by some estimations. And the population for the US, it's estimated to colonize about 30 to 40%. Most of the H. pylori infections occur during early childhood. It was originally thought to be transmitted by fecal-oral transmission, but the actual mode of transmission has not been proven. We do know that there are many risk factors for H. pylori, and those include low socioeconomic status, increased number of siblings, and having an infected parent, particularly when that parent is the mother. This is a schematic that I created just to kind of show you the scope of H. pylori disease. So most patients who are infected with H. pylori actually are asymptomatic. That may account for as many as 80% of those patients. Other patients can present with signs or evidence of gastritis, peptic ulcer disease, or gastric or duodenal cancers. The amount of patients with gastric or duodenal cancers is very low, much less than 1% of the population in the US. All of these patients with gastritis, peptic ulcer disease, or cancer may initially present with dyspepsia. So gastric cancer is worldwide the second leading cause of cancer-related mortality, which, that's not what we're used to reading about when we talk about cancer and cancer-causing mortalities. In this country, we tend to talk more about lung, colon, breast, and prostate being the big most common cancers, but across the world, gastric cancer is a big player. It can present in a very subtle way, and it often is very advanced at the time of diagnosis. We in this country do not routinely screen for gastric cancer, but certain countries have a much higher incidence, including Japan, Venezuela, and Chile, and those countries do screen for gastric cancer. So how does H. pylori relate to gastric cancer? There are some proven association and ways that we know that H. pylori works. We know that the bacteria can influence cell transformation through signaling mechanisms that happen with the molecular biology of that. And we also know that the bacteria, the presence of H. pylori, can directly induce chronic inflammation in the GI mucosa. Both of those factors then can lead into the development of gastric cancer. And there are two types of gastric cancer that can be associated, or that are associated with H. pylori. Those include gastric adenocarcinoma as well as malt lymphoma. So we're going to shift over to dyspepsia and talk a little bit about dyspepsia. That is a medical term, it's a clinical diagnosis. And there's a type of dyspepsia called functional dyspepsia. And functional dyspepsia is basically 1 month of epigastric discomfort without evidence of organic disease on upper endoscopy. This affects up to 30% of the population in this country, as well as Canada and the UK. And it has multiple factors, H. pylori being one of the big factors for dyspepsia. Other potential causes of dyspepsia include altered motility, immune dysfunction, and dietary factors. And diets that are implicated in dyspepsia include high-fat diets, diets high in wheat and gluten, high in FODMAPs, which are oligo and disaccharides that are fermentable, and diet rich in caffeine or high in caffeine and other chemicals can also increase dyspepsia. So with patients who have dyspepsia, we want to perform upper endoscopy for any patient who is 60 years or older with at least 1 month of dyspepsia symptoms. That is an expert recommendation, and the goal is to screen for and eradicate GI malignancies as well as other organic causes of dyspepsia, such as peptic ulcer disease. For patients who are younger than 60 years, it is generally not recommended to do endoscopy, but rather a test and treat for H. pylori strategy. And that has a strength of recommendation of A, which is based on high quality evidence. In patients under age 60, the presence of one alarm feature, such as weight loss, anemia, or dysphagia, should not automatically trigger endoscopy. And that comes with a strength of recommendation B. All of these recommendations can be found in the 2017 guideline on the management of dyspepsia, which was produced in by a joint effort between the American College of Gastroenterology and the Canadian Association of Gastroenterology. So how do we manage dyspepsia? Well, H. pylori eradication reduces dyspepsia symptoms by about 50% in one research study. And that carries with it a number needed to treat of 8 individuals to reduce their symptoms of dyspepsia. However, some patients test negative for H. pylori. And so if you're treating a patient for dyspepsia and you test them and they test negative for H. pylori, then at that point you start them on acid suppression, generally with a PPI. The PPI is more effective than placebo at reducing symptoms of dyspepsia, with a number needed to treat of about 14. Prescribe the PPI for 8 weeks, standard daily dosing. And if patients still don't respond with acid suppression, then you might want to consider TCAs, prokinetics, or psychological therapy. So what about GERD? What about reflux disease, and how does that compare to dyspepsia? So we all see GERD quite a lot, and we know that it tends to present with heartburn, this sort of ascending sensation of burning from the lower chest or abdomen up into the throat. Sour brash, which is that feeling of acid washing up into the mouth. Pharyngitis, dysphonia, and halitosis, all common symptoms of GERD. Dyspepsia is a different clinical presentation with epigastric pain or burning, postprandial fullness, and early satiety. Now, it's important to note that there is some overlap, and some patients present with both GERD and dyspepsia, and that may be as high as 50% of patients with dyspepsia who also have GERD, because GERD is very common. So how does H. pylori affect, or is it linked with GERD? H. pylori does not typically cause GERD symptoms. It is not thought to be associated there. Testing in patients with GERD is not recommended. In other words, when a patient presents with just GERD symptoms, you don't need to necessarily think to do H. pylori testing in that situation. However, if a patient with GERD is found to have H. pylori, maybe they present with GERD and dyspepsia, so you test them and they are positive for H. pylori, then treatment should be offered with the caveat that their symptoms of GERD are unlikely to improve with treatment. Endoscopy with biopsy is recommended to rule out cancer and other serious causes, as we mentioned, in patients who are 60 years or over. You also want to consider referral for endoscopy in patients under age 60 if they have more than one alarm feature. And we'll talk about what those alarm features are in the next slide. You also consider endoscopy for patients under age 60 who have a higher risk of GI malignancy, such as a patient who descends from Southeast Asia. They have an inherently higher risk and may warrant testing even under the age of 60. When endoscopy is performed, a rapid urease test, which is also called a CLO test, can be performed on the biopsy to rule out H. pylori. So if you're referring a patient for endoscopy, you don't need to order another type of H. pylori testing, such as the stool antigen or the urea breath test. So the alarm symptoms, I included the age of onset over 60 years in there, but that's kind of that's a major branch point in your diagnostic algorithm, because if they're 60 and over, you're going to generally refer for endoscopy. But for these other symptoms, these other alarm symptoms, if a patient has multiple alarm symptoms, 2, 3, or more, you may want to consider endoscopy. And so those include unexplained weight loss, dysphagia, adenophagia, persistent vomiting, GI bleeding, and you can see the rest on there. So when to order H. pylori testing? We want to have a tickle to order H. pylori testing in any patient with dysphagia. Again, dyspepsia, less than 60 years. Any patient who you suspect has peptic ulcer disease. Any patient with a known GI cancer, you want to test for H. pylori, and that's generally going to be done on an endoscopy. You also test patients who are asymptomatic prior to the initiation of long-term NSAID therapy, and we discussed that last week in detail. Also consider testing for H. pylori with unexplained iron deficiency anemia in adults with ITP. So there are a couple of different methods for testing H. pylori. The preferred method is a stool monoclonal antigen test. And that test is the best in terms of cost and convenience. We'll talk a little bit more about that in a second. The way that you order a stool antigen test on Cerner is the H. pylori antigen stool. There are a couple of different ones I've circled here with the red circle, and those are the tests that will get you the stool antigen. Those can be ordered out of our office. Those can be placed in a specimen container, just like a urine specimen cup, and they are sent to the lab. They have to be refrigerated and can be kept up to 72 hours, but the lab can run those through IU Health Lab. I don't have any idea on cost on that for our local testing. Urea breath test requires the patient to ingest urea labeled with radioactive isotope carbon-13 or carbon-14. H. pylori in the gut basically will cleave the urea into carbon dioxide, which is radioactive, and then that can be measured, which will produce a positive test if there's H. pylori present. That test can be performed here locally, and the way we order that is this outside H. pylori urea breath test. And then Wendy or Amy can schedule that. That test is performed at medical consultants here locally. And there are a couple other things, as you can see here. I just typed in Pylor in the search box, and it pulls a whole bunch of things. One of them is H. pylori screen. You can see that right about in the middle. You don't want to order H. pylori screen because that is the rapid urease test that is performed on a biopsy specimen. So you don't want to order that in the outpatient setting. You'll notice on here I've labeled the serologic testing as conditionally acceptable. Serologic testing is not recommended in general because it has a low sensitivity. And it is considered acceptable in patients with a documented peptic ulcer disease because the pre-test probability of H. pylori is sufficiently high that it actually leads to a reasonable negative predictive value of that test. But generally it's a second line, it's less preferred than the others. So stool antigen test, we talked a little bit about that. It's for test for active infection. It's not going to tell you about prior infections if the patient has been treated, although it can function as a test of cure. Sensitivity and specificity are close to 100%, so this test performs well. You do want to stop PPIs for at least 2 weeks prior to ordering, and that is to improve your sensitivity. And it is cheaper in relation to urea breath tests. So the breath testing also only detects active infection, also has a high sensitivity and specificity close to 100%, and you also need to stop PPIs. The big difference is that it costs more and it's just inconvenient for the patient. But again, can be ordered. We talked about the IgG antibody testing, but again, just to drive this point home, this testing cannot distinguish between an active and past infection. So this test has no utility in patients that have been treated previously for H. pylori. It's mostly used in research and population surveys. And again, it's considered an acceptable method only in patients with documented peptic ulcer disease without being treated previously. So this table shows you the accuracy of the different tests that are available. So this was taken from the American Family Physician in a 2015 article. Again, the urea breath test performs well. It shows the sensitivity of 97%, specificity of 100%. The stool testing also with a very high sensitivity and specificity in the 90s. And as you can see, the antibody tests, the serology IgG antibody tests only has about a 76 to 84% sensitivity and about an 80% specificity. So it just does not perform very well. So let's wrap it up today with talking about H. pylori treatment. These are general principles for H. pylori treatment. First of all, H. pylori should be treated in any patient who tests positive. Previous antibiotic exposure should guide the treatment regimen that you choose, because failures are common in the setting of antibiotic resistance. The table that I have inset here shows typical antibiotic resistance rates to H. pylori around the United States. And this is data from the VA study in 2009 to 2011. So there's scarce data on resistance rates. And even locally, we do not measure H. pylori resistance. So if you look at our ball antibiogram, you're not going to find H. pylori on there. I called and talked with our infectious disease pharmacist, and he says that our local resistance rates for clarithromycin hover around 15%. And that is consistent with the data that we're seeing in this study. We also can see that the rates of metronidazole resistance may be as high as 20%, and levofloxacin as high as 31%. So what regimens are recommended? These recommendations come from the American Gastroenterology, AGA, guidelines on treatment of H. pylori, and they recommend 3 regimens in particular. The first of which is the clarithromycin triple therapy regimen. This includes a PPI twice daily plus clarithromycin, twice daily plus amoxicillin or metronidazole, and that is given for 14 days. The bismuth quadruple therapy is a combination of PPI, bismuth, which is like Pepto-Bismol, tetracycline, and metronidazole. So those are 4 drugs, and of those 4 drugs, 3 of them are given 4 times daily. So adherence can be an issue with this. And the third recommended regimen is concomitant therapy, which has less data, at least from the US, but it is a combination of PPI, clarithromycin, amoxicillin, and metronidazole. So if you look back at the clarithromycin triple therapy, we list 4 agents there. You're choosing amoxicillin or metronidazole. In the concomitant therapy, you're choosing both. You're giving amoxicillin and metronidazole. Otherwise, those 2 regimens are very similar. So a little bit more detail now on the clarithromycin triple therapy. This is the regimen that is long considered the first line, and this is a regimen that is FDA approved for treating H. pylori. The combination, as we said, is PPI plus clarithromycin and either amoxicillin or metronidazole. The typical duration is 14 days. And the main thing is you want to avoid this regimen in areas where resistance to clarithromycin is greater than 15%. And use caution in patients with previous macrolide exposure. So again, our local resistance is around 15%. We don't have accurate data on this. So based on my discussion with the infectious disease pharmacist, one approach to take cure locally, and something that I might consider, is to ask a patient when, if ever, have you had azithromycin, erythromycin, or clarithromycin? Have they been exposed to any macrolide? And if they've not been exposed to a macrolide, ever or in the last few years, then I think consideration could be given to choosing clarithromycin triple therapy. Some of the advantages are these medicines are all relatively inexpensive, and all of these can be taken BID, which does improve compliance. So the bismuth quadruple therapy, this, based on the limited data of treatment effectiveness, has the highest eradication rate of about 90%. And that compares to most of the data on the clarithromycin triple therapy as about an 80% eradication rate. So this is a well-performing regimen, even in areas with high resistance to antimicrobials. This probably should be considered first line where clarithromycin resistance is really high, or in patients that have taken a macrolide in the past few years. This is a good option for patients who are allergic to amoxicillin, especially with a true penicillin allergy. And the big trade-offs are the increase in cost and the QID dosing, which is very, very hard to comply with. Of note, there is a product which is marketed in the US combining bismuth, metronidazole, and tetracycline. And that is FDA approved, and it is marketed under the trade name Pylori. And the dosing is 3 capsules, 4 times daily for 10 days. And then you would prescribe a PPI along with that. So here's the sticker shock, right? The approximate retail cost is about $950 for one treatment course. So I'm not sure how practical that is to use. You can prescribe all of these agents separately. Just note it's a lot of pills, and prescribing all of these separately is not technically FDA approved, although it is part of this guideline. So I think you're certainly well within your standard of care to practice bismuth quadruple, to prescribe bismuth quadruple therapy. And then just to touch once more on concomitant therapy, that is where you're going to combine PPI, both clarithromycin, and then both amoxicillin and metronidazole for 10 to 14 days. There's less evidence overall, but very promising international studies that say it's at least as effective as clarithromycin triple therapy. That makes sense because it is clarithromycin triple therapy plus the addition of either the amox or metronidazole. And so this is a very effective regimen. And if you're not sure about that local clarithromycin resistance, or maybe a patient took a course, a Z-Pak 3 years ago, and you're not sure how that plays in, this might be a good choice to consider for a patient in that situation. So basically what determines your success of treatment is the patient adherence first and foremost. If they don't take the medication, it's not going to work. And that's where the clarithromycin triple therapy has an advantage. The local resistance patterns, which we talked about, and then there are some patient-based factors that influence successful eradication, including smoking, diabetes, and genetics. Test of cure is recommended. Now, when I presented this last time, which was only a couple of years ago, at that time we said test of cure is not recommended because it is not cost effective. There's still a lack of scientific evidence for cost effectiveness. However, the AGA guideline published in 2017 does recommend doing a test of cure. That should be performed with a urea breath test or fecal antigen testing, or if the patient goes through an endoscopy, then that can be done on a biopsy-based, on a biopsy specimen. please note you want at least 4 weeks after completing the therapy for eradication, and you want to withhold the PPI for at least 1 week, 1 to 2 weeks before you do the test of cure. So when first-line therapy fails, and it inevitably will happen if you treat enough people with H. pylori, then you change to a regimen with a different antimicrobial pattern. If there is resistance, or I'm sorry, there's high resistance noted in many cases to amoxicillin, tetracycline, I'm sorry, I'm misspeaking. There's rare resistance to amoxicillin, tetracycline, and rifabutin. So regimens containing those antimicrobials tend to be used in the salvage therapy regimens. And my advice is if one of the first-line regimens fail, I would pull up the AGA guideline on treatment of H. pylori, because that goes through, it has a little flow chart and an algorithm that shows you kind of some of the salvage regimens. Of note, you can consider penicillin allergy testing for patients who are pen allergic. As we know, a lot of those patients do not have a true penicillin allergy. And so you can consider doing penicillin allergy testing and then maybe using a regimen with amoxicillin. And then maintenance PPI therapy is sometimes indicated after eradication of H. pylori, particularly in patients with persistent dyspepsia. Again, we said not all patients have their dyspepsia resolved with treatment, so some of them may continue PPI therapy longer term. And also those on long-term NSAID therapy, consideration may need to be given for a maintenance PPI. Just as a reminder, long-term PPI is associated with increased risk of several things, including Clostridioides difficile infection. So we want to use the least effective dose for the shortest duration. But again, sometimes the benefits outweigh the risks. So take-home points for today as we wrap up is we want to test and treat all patients with dyspepsia for H. pylori, along with our asymptomatic patients prior to initiating long-term NSAID therapy. Number 2, guidelines issued in 2017 by the AGA raised the age for endoscopy to 60 or greater in those patients with dyspepsia. Patients who are younger than age 60 should rather be treated as a test and treat for H. pylori strategy. When you treat H. pylori, you want to individualize the regimen based on patient factors and local resistance patterns. And again, applying this logic to our local resistance rates, I would think that at the very least we want to ask our patients, screen for prior exposure to macrolides, and if that is present, we may want to consider an alternative to the standard clarithromycin triple therapy regimen. And then lastly, a test of cure should be routinely performed to confirm eradication of H. pylori. And if that does not confirm eradication, if the test of cure is still positive, then we need to pull out our algorithms and look for a salvage therapy. And with that, I'm going to open up to questions and comments. I would love to take any questions from the group. Okay, do I have anyone? I'm going to make sure everyone's unmuted here.
I get it.
Okay, I'm not sure if I had you all muted, so I'm going to make sure you're unmuted. If you need to remute, you can.
Hi, Dr. Whitt, it's Kristen.
Hi, Kristen.
Hi, I was just wondering how many patients are you treating for H. pylori? So 80% of them would be asymptomatic. How many patients do you see that you're treating?
So just to clarify your question, are you asking how many am I currently treating for H. pylori, or what percentage? Are you asking like what percentage of patients with dyspepsia am I treating?
How many patients are you currently treating? I'm just curious.
Okay. Yeah, I'm not currently treating any patients for H. pylori. I have a very small panel, as you know, actually smaller than the third years. And so I am not currently treating anybody for H. pylori.
Okay. Is it pretty common? I guess the next follow-up would be, how many with H. pylori do you think are treatable or should be treated? Is it like 5% of those patients? Less?
Yeah, okay. I would say that, you know, estimates from the, going back to the epidemiology slide, estimates are that 30 to 40% of US patients have H. pylori infection. So that's, you know, about a third of your patient panel, statistically speaking, would have H. pylori infection. All of them who are identified should be offered treatment. And that is based on the fact, you know, it's, you're asking a very good question, because I also taught that 80% of those are asymptomatic. So do you screen all your patients, including those who are asymptomatic? No. So in reality, we're not going to be treating all of those patients with H. pylori, but anyone who presents for dyspepsia, the strategy is to test them for H. pylori, and if positive, then to go ahead and treat. And if they're if they're 60 and over, then you would consider endoscopy, have a low threshold for endoscopy. Does that help?
Yeah, it does. Thank you.
Great. Okay. Good question, though. Yes. Anyone else?
If I talk, hear me?
I can hear you.
Okay. This is Kelsey on Adam's phone. I have
Hi, Kelsey.
Jumping off Kristen's question, I had a patient in the last year who was, maybe it is more of a comment than a question. She at one point was being worked up for cyclic vomiting syndrome, and we wound up actually sending her for endoscopy because they were trying to, you know, figure out, is it actually cyclic vomiting? And it wound up being H. pylori as the presenting as cyclic vomiting. So I'd never heard of that as part of the differential, but that was much, much easier to treat than the ridiculous amount of like IV, like she was coming into clinic getting IV fluids and Zofran and all sorts of stuff. And it took 2 different regimens to get ready for H. pylori, but after it was gone, it took all of her symptoms away. It was amazing. So if you have patients that have nausea, that might be better.
Yeah. Thank you for that. So I have seen a couple cases of cyclic vomiting syndrome in my career. I'm sure it's more common, and I've been in full-time practice for 3 years. So I know during that time I had a couple cases of cyclic vomiting or cyclical vomiting syndrome. I don't believe I've seen one since I've been back here teaching full-time. But I do think, you know, persistent vomiting is one of the features of dyspepsia. I may not have listed that one, but when you have persistent vomiting, you should consider ordering H. pylori on that as well, in my opinion. Great. Other questions?